clinical experience, which we can then learn from and comment upon. So having said that, I welcome everybody, and I'm waiting, I'm excitedly waiting to learn something from today's presentation. So thank you all. Over to you, Dr. Eletu.
Thank you very much, sir. Dr. Odushote is our moderator for today, so I'll hand over to him to take over. Tunde, please take over.
Thank you very much, my boss, at least on many sides. So when I got this call to be a moderator, I was excited to do this. Number one, because my boss, Eletu, said I should do it. Number two, the presenter today is a very special senior friend, my sister, my big sister. We've come a long way. And I'm not surprised she's actually doing this. At least over the years, she's somebody who's interested in actually sharing knowledge and engaging in the space of knowledge sharing. And she is not afraid to break barriers and to challenge new ground. So I'm looking forward to a very robust presentation. And my sister, my big sister, you are welcome. And I'm sure you are not new. Dr. Moya is actually a pediatrician, but I would say she's also a medical entrepreneur. She is running a practice that's really an AA, a pride of pediatrician and in Lagos. And some of us are learning the rules from her after retiring from civil service. So my sister, please go for it. And we're looking forward to the robust session. Thank you.
Okay. Good afternoon, everybody. I don't know for how long I will keep my video on because of my Wi-Fi, the strength of my Wi-Fi. But I'm glad to be here sharing again with you all, and thank you for inviting me to share. The story of this is that Sanjay came to the hospital and I was ranting to him about some omission in the management of this patient, and he found it interesting and said to me, will you be willing to share this at this group? And I was quite happy to share it in this group. So my presentation. So Modupe is here guiding me very carefully. Modupe is my assistant. And what do I need? Okay, I go to. So, okay. So this is the outline my presentation will follow. Pardon? Pardon? Okay. So Modupe is instructing me, my executive assistant. Can you all see my screen?
Yes, we can see it. It's okay, ma'am. It's okay.
Yeah,
it's clear. Yeah.
So
Yeah.
Thank you.
So it's good. It's good. We are good to go, ma'am.
All right, thank you. See yourself. So it will follow this. How are we going back? If you follow this outline, I will give a summary, the background to the condition, including epidemiology, prognosis, and then I'll present the case, the investigation, the treatment, the outcome, and the follow-up. Then the learning point, and then a little discussion around it, because I don't think Moya is my main objective of presenting. I couldn't resist showing this picture. I'm sure we all miss it. So I'm presenting a 20-year-old patient, hemoglobin SS patient, who presented to the hospital. Sorry, I just need to get this off. With a one-day history of severe headaches, which he graded as 7 to 8/10, and pain around his head. He was managed by a multidisciplinary team, including myself, the pediatrician, adult physicians in the hospital, a hematologist, neurologist, psychiatrist, interventional radiologist, and an intensivist. Investigations which we carried out for him, he was in the hospital for a couple of days, so the investigations we carried out were extensive, but the only significant things were that malaria parasite was positive, he had hypokalemia, he had a mild leukocytosis and thrombocytosis. We started him on anti-malarial for his malaria, antibiotics for the possible infection. He was on anticoagulants and opiate analgesics in addition to his routine medications. He had an MRI with contrast of the brain on the 3rd day of admission. He also had a transcranial Doppler on the 4th day of admission, and were both reported as normal. On the 8th day of admission, he became unconscious, he developed seizures and isochoria. An urgent CT angiogram was done at a different facility from the first MRI, and it revealed multiple aneurysms in the brain, and a diagnosis of Moya syndrome was made. A plan for coiling of the largest aneurysm, which we thought was life-threatening, was to be done on the 4th of May by a UK-based neuro-interventional radiologist who consulted with him and his family virtually and was expected to fly into Lagos. It was confirmed because the HMO had authorized it. He was also commenced on nimodipine. Tragically, on the 2nd of May, 2023, his 11th day on admission, he developed an unshockable cardiac arrest and he died. A second opinion on the images of the previous MRI done on the 3rd day of admission identified that those aneurysms were obvious even on that MRI. It had just been poorly reported. So Moya means a puff of smoke in Japanese. It's a rare, progressive, occlusive disease of the cerebral vasculature with involvement usually of the circle of Willis. So this is a puff of smoke. Okay. So it involves the circle of Willis and the arteries that feed it, particularly the internal carotid. It refers to, sorry, how do I go back? No, I'm going, sorry, I can go backwards. This was the statement. Okay. It's not. Can you go back? Back. That's it, going forward.
Tonya, use the one in the bottom left corner, that arrow that is going backwards.
Yeah,
Yes.
okay, that's fine. Thank you. Yes, that works. Thank you. Yes, okay. I said it refers to the appearance on angiography of an abnormal collateral of networks. Collateral network that develops adjacent to the stenotic vessel. So there's a stenotic vessel, and adjacent to it, there will be a collateral network of abnormal vessels. It's usually bilateral, but may occasionally be unilateral. So pathologically, Moya disease, and you notice I'm saying disease and syndrome, is characterized by the thickening of the intima of the terminal portions of the internal carotid artery. The proliferating intima may sometimes contain lipid deposits. So the anterior, middle, and posterior cerebral arteries that emanate from the circle of Willis may show varying degrees of stenosis or occlusion. And then the thickening of the intima and waving of the internal elastic lamina and thinning of the media. But the most important thing is that thickening of the intima leads to stenosis of the internal carotid, and therefore the distal vessels to it now form small vascular channels that are anastomotic branches. The cause is not known. It is believed to be genetic, with 10% of patients having a family history. It is also thought to be autosomal dominant with incomplete step penetrance. People with Moya are found to have a high incidence of thyroid antibodies, and the significance of this is not clear, but it may suggest that immune abnormalities may play some role. Although it may occur in isolation, but several disease states have been reported in association, including Graves' disease, I mentioned thyroid earlier, infections, hematologic disorders, such as sickle cell anemia, as in this patient, congenital syndromes, vascular diseases, coarctation, of the aorta, cranial trauma, radiation injury, hypertension. While these associated conditions may not be causative, they impact treatment. Therefore, in the presence of these risk factors, the condition is referred to as Moya-Moya syndrome. So this child had sickle cell anemia and he had the Moya-Moya disease, which is why we call it Moya-Moya syndrome. It most commonly affects children. However, adults can have the disease as well. It is found all over the world, but most commonly in East Asia, especially Korea, Japan, and China. A study that was conducted in the US showed a higher prevalence, of amongst Asians, 4.6 to 1 white, 2.2 African Americans to 1 white, and 0.5. So it's least in the Hispanics and most in the Asians. The male to female ratio is 1.8 to 1. My patient was a boy. Sorry. For patients who present for treatment while the symptoms are still evolving, they have a prognosis that's better than those who present with already established symptoms. There have been various surgical modalities for revascularizing that have been suggested, but death is usually from hemorrhage, which is what happened in my case, in this case. And mortality is about 10% in adults and lower for children. About 50 to 60% of children or people who have Moya-Moya disease and who don't die will experience a gradual deterioration of cognitive function, most probably from repeated strokes. This young boy had been a patient of our hospitals for about 10 years. I first saw him as a child, but he was now an undergraduate at the University of Lagos. His mother had very good health insurance, medical insurance, which I will discuss at the end. He was first in a ship of 2, and his younger brother doesn't have sickle cell anemia. Despite his routine medications, he was on folic acid, he was on proguanil, he was on hydroxyurea. He suffered from frequent vaso-occlusive and anemic crisis. So he had had frequent exchange blood transfusions, he had had very frequent top-up transfusions, and he had used multiple facilities and was often in and out of hospital. We had considered, his parents or his family had considered a bone marrow transplant in 2018, but we could not pursue that course of action because they could not afford it. We had previously suspected that he had opiate dependence as the cause of his often very severe pain, which was not always, the cause of which was not always obvious. When he presented on the 22nd of April with a 1-day history of severe headaches that he himself even attributed to a stressful day and spending long hours in traffic, his vital signs were stable except that he had a fever, temperature ranging between 39 and 40. So he was placed on oral, he had a malaria test, obviously, which was positive, and he was placed on oral Coartem, acetaminophen, intravenous meropenem. Because he had hypokalemia, he was started on intravenous potassium chloride added to his intravenous fluids. And he was also placed eventually on subcutaneous enoxaparin and oral aspirin when we noticed his very high platelet count. He was also maintained on his routine folic acid, hydroxyurea, and so on. It is noteworthy that despite using opiates and other analgesic, according to our pain management protocol, which I will show, his pain never abated. It was always between 7/10 and 10/10. Let me see where the pain protocol further down. Why so far away? So this is our pain protocol here. So we used morphine infusion, we used pethidine. For him, we couldn't use diclofenac because something I omitted to mention is that he had had a nephrectomy earlier on in another facility. So we avoided using NSAIDs for him. Okay. So we followed that pain protocol, but like I said, his pain never abated. It never reduced to less than 7/10. Okay. On the third day of admission, we requested for an MRI with contrast. It was reported as normal. The following day, we had the transcranial Doppler done, and they said it was low risk. A neurologist who actually visited him on the 7th day on admission also found an impression of headaches in a child, in an HBSS patient, to rule out opiate dependence. Amitriptyline was prescribed, and it was recommended to have CBT by, and cognitive behavioral therapy. He had been diagnosed with depression previously. Depression is not uncommon on adolescents and young adults with sickle cell anemia. During the course of his admission, he was subsequently admitted into a high dependency unit on the 8th day of admission on account of seizures, anisochrenia, and coma. And he was also desaturated. So at that point, we gave him intranasal oxygen, we gave naloxone, diazepam, and his level of consciousness lightened. So we feared that maybe the coma was from opiates toxicity, which is why we gave naloxone. But the anisochrenia was difficult to explain. So we now requested for an urgent CT angiogram to be done at another facility. I think the neurologist asked us to do one, and that's what clinched the diagnosis of Moya syndrome. At this point, we discontinued the prophylactic dose of enoxaparin he was on, but we only reduced his aspirin. He made a full recovery, but was still in a lot of pain. The psychiatrist saw him at this point, and it was then that he also made the diagnosis of moderate depression and added escitalopram to his medications. We organized a virtual consultation with the UK-based neurointerventional radiologist. This was arranged for us by the body interventional radiologist who had read the CT angiogram. And his parents and his aunt, who is a doctor, were present. Also a representative of the HMO was there, and of course we were there. So we agreed on the plan to quickly coil the largest aneurysm, which was about 1.7 cm, and that's supposedly very large. As most the previous aneurysm that this patient had this doctor had coiled, the doctor was scheduled to come and coil an aneurysm 0.05 millimeters in another patient. But because they couldn't afford it, that plan had been jettisoned, but he still had his ticket and he hadn't canceled it. So when we called him, he was willing to keep the appointment on the 4th as he was planned to travel previously. But later that day, the child developed a supraventricular tachycardia. He became hypotensive. Then his ECG confirmed atrial fibrillation. He was intubated, commenced on amiodarone and noradrenaline, but he progressively worsened, and then he died on the 3rd of May. He was certified dead at 9:55 a.m. So the investigation that had been carried out with a positive malaria parasite, white blood count, potassium, the MRI, the transcranial Doppler, and the CT scan. I'd mentioned all this previously. These are the medications he had been on. I've mentioned each one of them at different times. His pain was managed according to our protocol using this medication. It's important to note that he was started on nimodipine when the diagnosis of multiple aneurysms was made on the recommendation of the specialists. The patient died, and his death prompted a wake-up call message from one radiologist to other radiologists that belong to his WhatsApp chat group. And I'm going to present I will present that. So this is the message he sent to his friends and to his colleagues, and he forwarded to me. He said, the MRI was absolutely not negative. I put this case here to impact upon you the need for us to continue to hold ourselves to the highest standard in providing radiological services for patients in Nigeria. The above patient, the MRI was done at, I deliberately have exploit this, because the idea is not to run any facility down or any individual, but just for us to learn. 7 days before the CT was ordered for sickle cell patients who complained of intractable headaches. Unfortunately, the MRI was cold and negative. The physicians remained worried and called me. We ordered the CT angiogram of the brain and found a large basilar aneurysm in addition to multiple other aneurysms, in total approximately 8. We consulted on the patient yesterday with a plan to arrange a neurointerventional radiologist to fly from London to intervene. Unfortunately, the patient died. He said same night, but it was the next morning. It was a 20-year-old patient. And I think the most important thing he said was that there are lives at the other side of every scan. They are live at the other side of every scan, every test, every history, is a life. Then he said to me, this was my message to all radiologists. This is an incredibly sad case. So I'll go back to. Okay. So what are my learning points? First, that it's important to have a multidisciplinary team in managing patients more and more. And I'm glad we had one in this case. Secondly, is to avoid mind traps, jumping to conclusions. We should always give a patient the benefit of the doubt. And in saying this, I'm referring to myself inclusive. We were quite, after a while, we had all become convinced that he was opiate dependent. And so even his parents believed it too. So anytime he came with this, his pains, we all thought he was the opiate dependent. So yes, it exists. And I have patients who have become opiate dependent, but not every patient. So maybe we should give patient benefits of the doubt, because at a point we will sometimes even just give him a placebo water, injection water, you know. But this boy was obviously in a lot of pain. And then, of course, there's a need to hold ourselves to the highest standard in providing, you know, care to our patients. So this is radiological, but care for all of us as doctors. And also, I learned the value of a good medical insurance. The medical insurance did not, the health insurance did not bulk for 1 minute. I carry them every step of the way. They will actually visit. But this boy had been a patient, not just to us, but also had been insured by this organization since he was a child. So everybody had some kind of emotional attachment to him. So the people from the insurance were here to visit him. They came in when he died as well. And at every point, even without getting authorization from head office, they would say, go on, Dr. Onya, go on. At the end, we'll sort out the payments. And also to say that pharmacological therapy for Moya is often disappointing. So what can be useful? Management of hypertension if present, but this did not happen in this case. We did not have hypertension. But nimodipine is indicated for the improvement of neurological outcomes. I had a brain hemorrhage about 2007. I don't know how many years that is now. And I now was placed on nimodipine. And they say it works by reducing the incidence and severity of ischemic deficits with subarachnoid hemorrhage from ruptured buried aneurysms. But nimodipine also causes cardiac arrhythmias. I remember when I was on nimodipine, I thought my heart was going to jump out of my chest. Actually, after a while, I stopped taking it. You know, it caused cardiac arrhythmias. We gave this child 1 or 2 doses of nimodipine, and then he develops an atrial fibrillation. I'm not saying it's causative, but you never know. So for patients, so in his own case, he was at risk of a hemorrhagic stroke from the ruptured aneurysm. It's possible he had even bled, we don't know. And then maybe he had a second bleed that killed him, we don't know. I think I have said most of these things, but I think this was the most important thing I wanted to say. And this is actually how Sende and I got to decide that this presentation should be made, because I was griping to him about how he wanted me to do an MRI in a particular facility. And I said to him, no, I'm not going there. And I told him this story. And then he said to me, please use that facility, but bring the images. Somebody will get somebody else to report it. So poor reporting of radiological images and their implication. This is what we got. It says no significant abnormalities seen.
It's very hard to tell you exactly what's on label of video, so I'm going to just show you what I'm looking at here.
Okay.
So if you look at this MRI, that's the aneurysm right there.
So it's not showing. Where the video? Sorry, this one. Okay.
It's very hard to tell you exactly.
Sorry, it's not showing.
Video, so
But he sent me an image of the MRI
right there,
and to show that
pause it and show you.
okay, let's see if it will show. Unfortunately, it's not showing.
There. It's called a flow void on MRI. And then
I'm sorry, it's not showing, but he sent me a video showing that the MRI showed up on this, even on that. Okay, so this is the CT. I think it's the CT angiogram showing us the hypertrophy of the lenticular striates, arteries as collaterals. And then this shows us the large basilar aneurysm. Sorry, where is it? Can't find the video. Okay, it's moving now. Okay, then this shows the narrowing of the middle cerebral artery here and the narrowing of the terminal internal carotid artery, typical of Moya. So I think that's my presentation. And then this in memory of, so this is like a little image of my patient's AEO. I got the permission of his family to show this picture. That's it.
Thank you very much, Ma, for a lucid case presentation and lesson advance. So the floor is now open for discussion, question. You can choose to raise up your hand digitally so we can call you to speak to your mute, or you can type in the chat box. So let's go for it. Thank you.
Stay inside the web.
So the floor is open for questions, comments, and so if you want to put on the chat box, feel free to do so. I'll read that. And if you also want to put your hand up digitally for us to ask you to speak up, we'll be able to do both. Thank you. Well, let me start by saying this was a very important learning curve for me, and I think it's also appropriate for us as physicians to look back and do what we need to do. One of the areas I've also have struggled is there's a center that sends X-rays to my units, and I've struggled with the reporting. So I think this will also be a point for me to insist and to engage with them now that we're learning something new. There's a chat. Okay, Dr. Zudima is saying, thank you for the presentation, excellent work. Please do you have a copy of the EEG?
Did you say EEG or ECG?
I think it's ECG. Sorry, ECG. Sorry, my bad. As I say, ECG.
No, I suspect that the atrial fibrillation we saw was probably on the monitor. I don't. The patient was in intensive care at the point, so it was probably the patient monitor.
Okay, she was asking, is there any intervention?
Yeah.
Any intervention? Whether there's any intervention at that time when you notice the SVT?
I thought it was placed on amiodarone, intravenous amiodarone. That's all I know we did.
Thank you, ma'am. Thank you very much for the feedback. So any other question, you can put on the chat box or you can choose to just...
My hand is up, sir.
Okay, go ahead, sir. The boss himself.
Okay, thank you very much. I just want to thank Dr. Onye again for sharing this case with us. Like she said, this happened when I was at her facility to discuss doing an investigation with for one of my patients, and she told me about this. And it's extremely important that we learn from this lesson that when we get a particular report and we are not happy about it, we should always seek a second opinion, which was what we did in my own case. We got the X-ray, we got the CT, the reports and the films, and sent to another facility entirely to read for us. Because sometimes second opinion may make a difference between somebody being alive or dead. So, and she will also tell you, I also had a personal experience where my daughter was ill and was in a hospital, and a doctor there had suggested surgery. But I just said, look, I wanted a second opinion, and I took my daughter to Dr. Onya's facility, and lo and behold, there was absolutely no reason to have surgery done. So it's a very, very important lesson for us. The question I want to ask is, did we at any time try to get an autopsy done on this case? Were the parents willing, or we just didn't want to add to their sorrows by asking for an autopsy? Thank you.
Well, I thought it was kind of obvious to us that he had an intracranial hemorrhage, but the parents took him very quickly and went to bury him same day. I don't want to say they refused an autopsy because I don't remember clearly if we discussed it. We're all very distraught. So I don't remember clearly if we asked for an autopsy, but yeah, but they buried him same day, I think, because the mother came in and we told her the dad was in Moya or somewhere. He had to drive all the way back, to VI, and then they took him away immediately. But I think it was clear to us because our biggest fear was that big basilar artery will rupture, which is what we wanted to coil, and we believe that's what ruptured.
Thank you very much, Matt. There are two questions or comments on the chat box. Do you want me to read that for you, or you want to read it now?
Let me see if I can find them. I can't find them. So please read them for me. Why can't
Okay, so this from Dr. Orode Duarte. It seems sad we now have international radiologists in Nigeria. I will still miss this. Painful. How do we support more training for radiologists? Are they doing more? Have we gone back to the actual facility to show them the miss? That's a question and comment.
A very good point. I tried to reach the MD of the other facility, and that's a very good question you asked. Other facility you asked, you mentioned the other facility, the first facility, but no, I think I'd reach them for another case. So to be honest, maybe I'm just not happy with that facility. And if I have my way, I never use them. That's the truth. But I don't always have my way because of the HME. So the interventional radiologist is in one facility. We have just one in one facility. And I don't know that so far they've reported anything that has been wrong to me. But this other facility, often will give me wrong results. And I think I have spoken with the MD. Yes, I actually have the number. But what I don't remember is if I discussed this one with her. So I will make sure that after this meeting, I will report this to her. I will share the presentation with her and I will tell her that the first facility was hers.
Thank you very much, ma'am. The second comment is, please, what was the hypokalemia corrected? That's from
Potassium
Dr.
chloride.
Aisha.
It was corrected with potassium chloride and it normalized. I can tell you what the final figure was. Let me open this. So we do the correction based on the calculation and we do it over 24 hours, 48 hours. So potassium chloride intravenous included in its intravenous fluids. So it normalized. It was on admission for 11 days. And the hypokalemia was on admission.
Thank you very much, Mark, for the response. We still have time for questions, comments. You can type on the chat box or can raise up your hand to ask questions.
Sorry, already, yes, I did send a message to her. Yes, on the 3rd of May, I sent, so I wasn't quite sure. I didn't want to say what I didn't know. So I spoke to her. She said she will investigate and come back to me. She never came back to me. So I will follow up and say, I haven't heard from you again. I'm sending that now.
Well, the big boss has said, I think, let me just read, Dr. Little has something in the chat box, which I want to read. So he said, I think we should engage the local international cardiologists so we can all benefit from his or experience. Well, I guess it's something to do, but I also know that we can overwhelm him. For me, what I think we need to do is to encourage him to share knowledge. I think knowledge sharing will be a good way to go to engage the residents or the concerned who are willing to learn. So I think it's, if you ask me, the best thing, apart from engaging him, to also encourage him to share knowledge, organize short courses for people that can come hands-on, and then for a fee, not for free. And people like the big boss, can actually sponsor such sessions. Thank you. Any other comment, question for Dr. Onya? You can type it on chat box, or you can raise up your hand to tell him. Okay, thank you, sir, Dr. Little. No, so you are saying you are going to sponsor one of these events?
Sorry, I dropped off for a minute. So I thought he set up something called AccuRead. So where you send your images to them, and there are a group of radiologists all over the world who report, in that group.
So just to clear on that, can we as patients send our report to that group, or has to be radiologists alone that can send to that group? Just to clarify, ma'am.
Anyone can send to them.
Okay, thank you. So I think that's also under information that if you have doubts. So maybe you can share the details of how to reach that group on the chat box. And we can also ask Dr. Little to please make it available on the group afterwards. So if you have this information how to reach the group, can you please type in the chat box or reach out to Dr. Little after this meeting? Because I think that's very useful if you have doubts about your imaging report. I see that Dr. Yan also left, maybe because of our network.
My network, but I keep going and coming back. Okay.
Yes. So I was just asking, do you have information how to read that group with our images?
No, I just send to Nino Lowo. That's what I do. There must be a way rather than sending directly to him. I just send to Nino Lowo. Okay, already I've shared the number for us. Savannah at AccuRead. Yes. So I just send to Nino Lowo. But I think this number is probably the better number to use. But then, I mean, although this is a radiology one, the truth is that it is not uncommon that we misinterpret a lab test, an ECG, an echocardiogram, and then we have bad outcomes at the end. So the point is that we should remember always that behind every investigation is a life at stake. I think that's it.
Thank you very much. The point is well taken. So I think the takeaway from this meeting is that if you have doubts, please clarify your doubts and flag it up with somebody that will help you. Thank you very much, Manso. Any other comment, question?
Can I ask a question?
Yes, please.
Go ahead, sir.
Yes, sir. Dr. Dushote, can I ask a question?
Yes, go ahead, ma'am.
Dr. Onya and all right, Dr. Onya and Orode, please, is it possible to get the phone number of Nino Lowo? I intend to engage him and see if we can, during one of our presentations, if he can come and talk to us and we can share some of the problems we're facing and how he can help us as a group. So maybe you can send his number to me. Oh, okay, I think you've sent a number already.
No, that is Susanna's number. But
Oh, okay.
But I think we will share in on the whole. Yes, he's very happy. Like Corday says, he's very happy to engage and share information and share knowledge.
Fantastic. So I can speak with him and get him a slot during one of the in the next few months and see if he can talk to us as a group.
So to the doctor who asked about the hypokalemia, the last potassium I can see here, which was done on the 3rd of May, the result was 3.78, which is within normal. To be corrected, the hypokalemia.
Thank you very much, ma'am. So I think I can still pull my boss leg. It's good that you come to talk to us, but can you also set up a meeting? No, I said it's good that the letter says he can come to talk to us as a pediatrician, but I'm just saying that I want to pull his leg a little bit. That's a big boss. He can also set up a meeting to train or to empower radiologists in a meeting that his company will sponsor. Thank you, sir, for saying yes.
No problem. Professor Green's hand is up. Please, we need to acknowledge her. Please go ahead, ma.
Yes, so good morning, all. I'm so sorry I was late, but part of the reason I was late was because I was trying to use the bit.ly address and I couldn't navigate it very well. However, I stumbled on the fact that Ngozi has actually got quite a lot of educational materials on her platform. So, I mean, it's just incredible that you have all that and we don't know anything about it. So I was now trying to find out where your Moya was, but it's not there yet. Would you please put it there so that I can catch up with the presentation? Is that possible? Ngozi?
Sorry, ma, I didn't hear you, ma'am.
Oh, you didn't hear me?
Yes, because I dropped off for a while.
Did anybody hear me?
Ma, you can still go ahead and let her know your viewpoint, man. So we have time, man.
Yes, your bit.ly platform, bit.ly, the one that with the picture.
Yes.
I was trying to get into this webinar via that address. You had put there on the picture that one could use that or scan a code. Is that correct?
Okay, that's Sande's question. Sande, you should answer that question.
Okay, thank you very much, ma'am. I will send you a copy of the presentation personally, apart from sending to the group.
Okay.
Maybe in the next 24 hours so that you can catch up with the presentation, ma'am.
However, Sande knows that I'm very curious about all this technology. He knows that.
I know, I'm aware.
And I just wondered because some of your past presentations are there on your platform. Did you know that, Ngozi?
Yes, ma'am.
No.
Each month we'll try and update it. So I'll put it up as well.
All right. Okay. So sorry to have been late, but I caught a little bit of what was going on. The disease Moya thing is sort of out of my radar, off my radar right now. But anyway, well done for
It's off everybody's radar. I never heard of it until Lobo said to me that this is Moya. What is Moya? All right.
That's very good. Excellent.
Thank you very much, ma, for your contribution, ma. We appreciate your being here regularly. I think you're one of the regulars. So, Dr. Letu, you are arranged for a reward or an award for Prof. For one of the circumstances.
Yeah,
yes, ma. I have to encourage you, ma, for spending time with us
it will be delivered. It will be delivered in January when she is around for Pancov.
That's a question.
I thought a little. So that's very kind of you, man, for the input. But I also we ensure that we're up to date, and it's also a learning platform for everybody to go back and listen to some of the talks I've been giving here. And it's a very good resource for training and for updates. Thank you very much for the comment, man. We appreciate that. So any other comment or questions before we call it a day? I guess it's been very useful. I think the learning curve is the fact that we need to double check if you have doubts about your results or everything that you have done across board. And I think we also need to engage with it. We have a lot of people who are available, are accessible, even within and outside this country that can be of help. I've had to reach out to people in my space, other host friends who train Nigeria, or actually have some other training in some of the areas that we need. And it's important for us to reach out to people, especially if you know if they have other skill sets that you require for your patient care. So any questions, comment before I hand over back to my big boss, Dr. O.B. Eletu, Chair, LOC, Lagos, Eko Akete 2024.
I think
okay, thank you.
Wrong diagnosis. I think in addition to the wrong diagnosis, we must also commend the HMO that was willing to go as far as bringing in a doctor to save the life. And what I didn't mention is that this child's family is a lower middle class family. I mean, they couldn't afford the transplant, bone marrow transplant in 2018. So they are very lower middle class. They live outside Lagos in Ogun State, but the mom works for a very good company, so had a very good medical insurance. I think this truly understood, and nothing was withheld from that child. Everything we asked, we are authorized to do. Everything we asked, we are authorized to do. So I think the importance of a good medical insurance cannot be overemphasized as well. And I hope we all have medical insurance. Saying you may need to, you're an insurance man, you may need to increase your premium so people can get better insurance.
Dr. Onya, what was the insurance? Who was the insurer?
I didn't want to promote anybody or demote anybody. But it was Liberty Blue. It was Liberty Blue.
Liberty Blue. Okay.
Total Health Trust. Yeah.
Are they still there? I thought.
Yes, they are still here.
Okay. Thank you very much. Already, thank you for a very kind comment on the chat. I see that, but I'm blushing now. So maybe I should start another line of business of hosting events at MC and all that. That's what you're saying to me. So I'll work on that. So Dr. Letu, over to you in absence of any other question or comments. Thank you.
Thank you very much, Dr. Onya. Thank you very much, Tunde, for moderating, and also to just add to what Dr. Onya has said. Yes, we should get good medical insurance cover. We should also, at any point that we think we need to get a second opinion, please, we should not hesitate. We should go for it, because sometimes it can actually save somebody's life. Before we round up, I just want to ask Dr. Mbojeli Lawal, our chair, to say one or two words, and then we can close the meeting. Over to you, sir.
Okay, thank you very much. Nothing much to add to what has been said. I think you have sort of summarized it very well. Only to acknowledge the presence of Professor Grinch, who is always finding time to be with us, and all other colleagues who are present on the platform. When I saw the topic, I said this rare something. Okay, but I always thought that Dr. Onya would make it interesting, and or present an interesting aspect of it, which is exactly what she has done again today. So thank you very much, Ngozi, for this very, very good presentation with very clear points to take away. Thank you again. Over to you, Dr. Eletu.
Thank you, sir.
Thank you very much, sir. A big thank you again to Ngozi for sharing this. And, each time we talk and we discuss cases, I always learn from you. So I also want to use this opportunity to thank you for saving my daughter from having an unnecessary surgery. Because if I hadn't brought her to you and I'd remained at the initial hospital, maybe she would have had a scar now that she didn't need. So thank you very much. Of course, to also tell each and every one of us, when we have interesting cases, please be ready to share with us. I mean, this platform, like we've always said, is a learning platform. We all learn from one another. I can tell you that in the month of August, we're likely to have a presentation from Reddington Hospital. I was approached by two of the pediatricians there that they have a very interesting case that they are working up for presentation to us. So we look forward to that time. But next month, we're going to have a case, well, most likely a case report. I'm yet to get the full topic from one of our colleagues in the northern part of the country. As we say, medicine is not located to any part of the country. So we want as many colleagues all over the country to come and talk to us. So we'll see you in the month of the 4th Thursday in the month of July. Unfortunately, we've had to do this. This is not the last Thursday for the month because we're anticipating a public holiday next Thursday. And that obviously will have meant that we may not have the crowd that we had today for this presentation. So thank you all for your contribution. I will, on your behalf, contact Noluwo and see how we can also schedule him to present to us and we can all learn and share from his wealth of experience, and then we know how to contact him for future cases. Thank you all. God bless you all. Thank you very much. Bye for now.
And a quick thing, Dr. White asked if it's for a fee, and I responded, I said yes. It's 40K, second opinion. But if you do the CT scan with them, you get it, you get their opinion.
Okay,
thank you, man,
that's
good.
good.
That's very valuable.
Okay.
So thank you, sir.
Thank you. Thank you, everyone.
Thank you,
sir.
Bye-bye.
Thank you. Bye for now.
Bye.